So if folks have been to an I-STARR webinar in the past, you might recall that the I-STARR project is supported by a grant from the National Institute on Drug Abuse. It's also part of the larger NIH Helping to End Addiction Long Term, or the HEAL initiative. And it's one of several projects that comprise the Consortium on Addiction Recovery Science, or the COARS network. Let's go to the next slide. So I'm Dr. Amy Miracle, and I'm a research scientist in the Alcohol Research Group at the Public Health Institute. I co-lead the I-STARR project with Dr. Carmen Masson, who's a professor of psychiatry in the School of Medicine at the University of California, San Francisco. But the team also includes some real superstars. We have Sarah Zemore as a co-investigator, as well as Lenny Jason. We have biostatisticians Meena Subbaraman and Libo Lee, communication specialists Diane Schmidt and Dustin Kebzu, and the team is coordinated, the whole project is coordinated by Quinoja Capitani. Let's go to the next slide. So the I-STARR project activities are guided by a 17-member advisory board, and our advisory board is comprised of a diverse group of leaders from across the country. Our advisory board includes or represents folks who are leaders in the recovery and recovery housing field, treatment providers and payers, national policy advocates, as well as researchers and educators. We'll actually be hearing from one of our advisory board members today. Next slide, please. So let me tell you who you'll hear from today. I'm very excited to be introducing Dr. John Major, who will be presenting findings from a number of studies that he's conducted on the topic of MAT among Oxford House residents. So Dr. Major is a professor of psychology at Harry S. Truman College and a private consultant who earned his doctorate in clinical psychology with an emphasis on community psychology at DePaul University. He's conducted research with individuals recovering from substance use disorders living in recovery homes for the past 30 years, and was appointed to the American Psychological Association's 2009 Presidential Extended Task Force Network on Psychology's contribution to end homelessness. In addition, he has over a decade of clinical experience with this population, including those with co-occurring disorders. Dr. Major has provided expertise in legal matters concerning recovery homes for members of the court, private attorneys, recovery home operators, and the U.S. Department of Justice. So without further ado, I want to turn our attention to Dr. Major, and I can't wait to hear what he has to say about his work.
Oh, thank you very much, Amy. Good afternoon, good morning for some of you. My name is John Major, and I'm going to talk about some research involving medications that folks use in the treatment of their opioid use disorder. As Amy said, we refer to this as MAT or MOUD. When I started looking at this, it was DRT, then it switched to MAT. So I make a lot of reference to MAT for most of my studies, and toward the end, I kind of come back around and use the current acronym MOUD. Today's presentation is going to give you an overview of some of the research I've done in the last 6 or 7 years. I'm going to kind of quickly go over 5 studies. This primarily involves Oxford House residents, some who have used MATs, some are presently using MATs, and some who never had used MATs. And I'm hoping to draw some implications at the end and then throw it out for a general discussion. This will be about 45 minutes, and we'll see how it goes. All right, the first study I like to discuss, I refer to as the Washington College study. One of my colleagues, Christopher Beasley, who's now on the West Coast, doing research involving folks who are justice-involved individuals. He kind of got away from this line of research. So I was asked to take the lead on this and analyze a data set of data that he and others collected. We were looking at medication use among Oxford House residents. This is the first study of its kind. There was a paradigm shift going on with the Oxford House organization at that time, where we started seeing more folks coming in on medications. Only a few years before that time, This was not a practice, so we thought it was important to tap into the attitudes residents had with respect to prospective members coming in on medications. So in doing so, we collected some data on various characteristics of residents, not just those using medications, but those not using these medications. And we tapped in their attitudes and tried to understand a pattern with the data. The data came from one state, the state of Maryland, primarily the Eastern Shore, which is just east of the Chesapeake Bay Bridge. At that time, we had about 20% response rate of all residents living in Oxford houses in the state of Maryland. But we didn't get so many folks who were on medications. There weren't too many to obtain data from at that time. But the people we did survey, we asked them to report their historic and current utilization of medications for opioid use disorder, or MATs, things like Suboxone, methadone, Vivitrol. And then we asked them 4 questions that tapped into their attitudes with respect to these medications. There are 2 sets of questions. The first set asked whether participants felt that they thought residents using medications were using addicts. In other words, they didn't stop using their drug use. We asked them, did you think that was the case, whether the medication was Suboxone, which I think we listed as buprenorphine/naloxone, and methadone. The other set of questions asked them, would you vote against, definitely vote against having a prospective resident on one of these medications into your Oxford house? So an endorsement of these 4 items, any of these 4 items, indicates negative attitudes toward MATs. So we got the data. It was just enough for us to do our research, and we put participants into 3 groups to better understand these attitudes. One grouping had to do with respect to their opioid use, their historic opioid use, whether their drug of choice was opioids or heroin. So we had about 31 folks saying that their drug of choice was heroin or opioids. And then we were able to split them into 2 groups, those presently using MATs and those not presently using MATs. So we looked at their attitudes in comparison to a non-MAT other group, meaning their drug of choice was anything other than opioids and they were not presently using MATs. We thought, based on some of the anecdotal evidence, that there is a bias against people coming to Oxford House on these MATs, primarily from people who used to use opioids, thinking, hey, I didn't have to do that, therefore you don't have to do it, something like that. And maybe the other group was kind of ambivalent about it because, hey, I don't know, maybe it's a good thing, maybe it's not a bad thing. We also collected some other information based on the length of stay, their 12-step meeting attendance, how long they reported they've been clean and sober at this point, regardless of their medication use. And we found there were no differences between the groups on these important recovery markers: continuous abstinence, continuous time living in an Oxford house, and weekly 12-step meetings. Hey, it sounds like this model is effective for folks on medications. We found that about 1/3 of this sample reported a history of having used medications in the past. And presently, about 20% of those using medications currently reported that they never got a prescription for their medication. In other words, they were using their current medications by way of diversion. This table is pretty much what was presented in the report that got published. I'd like to highlight some things to bring your attention. First, when it comes to having a history of using MATs, if you look at the first 2 groups, starting from the left, the MAT group column, going to the center, the non-MAT opioid group, you have 2 groups of folks whose drug of choice are opioids or heroin. One group currently using MATs, the other group not presently using MATs. And they have the same proportion of historic MAT use. So that's interesting that now we have the bulk of people whose drug of choice are opioids having a history of using MATs, but they're not using it now. And we have about 1/3 of this group of folks presently using MATs. Now you might be kind of wondering, well, what's that 9% there, John? Well, it's possible that some people in the other group received something like Vivitrol for their alcohol use disorder, but that's speculation. Okay, let's take a look at what the results were with respect to endorsement of these positive endorsement of these items, which would indicate negative attitudes. I want to pay attention to the middle column and the far right column, the non-MAT opioid group and the non-MAT other group. If you look at their numbers going down the columns, you'll see here for the first question, 38%, 54%. And underneath it, 62%, 40, and you keep going down. Well, with respect to the positive endorsements, the numeric difference are not significant. In other words, the proportions are statistically the same. The same amount of folks in these two groups reported a positive endorsement of these items. In other words, negative attitudes. And these were at a higher proportion compared to those using MATs, those in the MAT opioid group. So 38%, 54% statistically the same, but significantly higher than the 0% of folks in the MAT group. And this was a pattern across all four items. You see that the numbers are larger when the medication happens to be methadone. That the participant said, I feel that if you're on methadone, you're still using drugs. And this is at about a rate of about 2/3. But what's interesting is that those in the MAT group, those presently using medications, 22% of them said, yeah, if you're using methadone, you're using drugs too, which is kind of interesting. Now, when it comes to definitely voting against a prospective resident who's on one of these medications, there was negative attitudes, biased among those in the non-MAT groups. 33%, 39%. So about a third of them said, I will definitely vote against an applicant who comes in on Suboxone. And when it comes to methadone, the number is nearly double. About 2/3 of the non-MAT group said they would definitely vote against somebody coming in whose medication is methadone. Whereas folks in the MAT group, 50% of them were down on methadone. Interesting. So, how can we interpret these findings? One way is that, well, the majority of residents, especially those with an opioid history, are not using MATs. So MAT use among Oxford House residents isn't that common. 1/3 of the sample reported a history. And if you think about it, out of those people who have a historic use of MATs, there are twice as many more of them not using MATs compared to those presently using MATs. And I've heard this going to Oxford House conferences among ex-heroin addicts saying, hey, I was using these medications, therefore these new guys, they're using medications too. They don't need this. This is going to, pollute our system and all this kind of crazy thinking. And the next study, I will maybe uncover maybe a little more truth about what's really going on with that type of attitude or bias. But I think it's fair to say, and the reality is, as I understand it, for some people, going into an Oxford House is a viable alternative to being on medications, or maybe the person realized I'm not doing medications anymore. Hence the reason to do more comprehensive investigations to see, well, if people are on a taper effect, is recovery home living like Oxford House helping them? What is it about it that's helping them maintain their absence and then eventually getting off the medication or maintaining their maintenance program as prescribed by their physician? And I think it's safe to say for some residents, their historic MAT use was an extension of their drug use. And the next study will shed a little bit more light on that and why, if that is going on, it's unfair to project that onto current residents. I think this in part explains the negative attitudes, but not completely. The results in the next study will add another piece to that puzzle. It's kind of weird that there are more negative attitudes against methadone use, even among those currently using medications such as Suboxone. Maybe it's because there's 6 decades of methadone use or history or research versus only about 2 decades with Subutex and Suboxone. I don't know, but it's something to consider. It's something to consider in that identifying with recovery home residents with peers is essential. Not everybody needs a recovery home. Not everybody needs medication. Not everyone needs outpatient therapy or detox, what have you. Not everyone needs recovery home living, but some people, and I think the number is bigger than we first suspected years ago. For some people, the only way that they're going to recover is through recovery home living. Like for some people, the only way they're going to recover is through the use of medications. So I believe that having more residents in a house, one of my first studies I got published on Oxford House looked at identity issues, that I need to have some kind of common ground with a fellow resident. And if I don't, we realize that that is going to impact their self-advocacy for their abstinence. So if you have some people with different medications, that could have some impact on recovery outcomes. In that if I come into a house on methadone and there's no one else on methadone, but these people are on Suboxone, I might get the cold shoulder from them. This has implications also for sober home living rules. The point here is that these findings suggest that there are some potential identity issues that we need to consider when doing research with people on MATs living in recovery homes. The rates of diversion was kind of surprising, but this is at a time in history, I think it was 2014, 2015, where residents weren't coming in too much into recovery homes. This was the beginning of it. And there was some illegal use of these medications by some residents. So I think recovery homes have gotten a bit better in carefully selecting and screening and asking prospective residents to see the prescriptions for the medications that they're on to prevent diversion from happening. Okay, there was still a negative attitude, I think, over the majority of residents in Oxford House at that time. I think it's safe to say that, half of them thought, whether they were using opioids in the past or not, half of them thought that using medications of any type is still an extension of their drug use. I don't think that this is characteristic of Oxford House residents. I think it was characteristic of these residents in one location, the Eastern Shore of Maryland, at a time where there was a great sense of antipathy, if you will, or resistance against people, or ignorance against people coming in on MATs. But when I look at the findings long enough, I think that the negative attitudes are not solely based on one's drug of choice of using opioids. And the next study will kind of add some pieces to that puzzle. All right, so that was the Washington College study. It's one of the most cited studies that I noticed when I get emails from researchgate.net. And I hope people are not using them to say, this is the state of the art of what's going on in recovery homes or recovery residents with people on MATs, because that is not the case. It was the first one, and that kind of gave us some insights into going further. So the next several studies that I'm going to discuss, I call the Truman College study, where I created the research method design and some methods about better understanding the findings that I presented just now. That is one thing to consider, maybe drug history and understanding his attitudes about MAT use, but what about proximity? It doesn't matter if I'm living in a home with another resident who's on MATs. And then in a few studies I'll talk about toward the end of my presentation, I'll talk about a sense of homophily. Doesn't matter if I'm on MATs and there's at least one other person in my home. So that's sort of what I'm getting at with proximity. Maybe we need to understand proximity effects in addition to historic opioid use, in addition to historic MAT use, to better understand residents' attitudes toward those presently taking medication-assisted treatment. So in this investigation I'm going to go over now, we got a bigger sample across about 25 of the United States, a more representative samples, cross-sectional data. But we were able to create 3 groups to understand that drug of choice by proximity effect. By saying in one group, we're looking at folks, they're in an Oxford house, they are not on MATs, and no other fellow resident is on MATs. That is the non-MAT house. We have nearly 100 folks in that group. And then the second grouping, MAT house, meaning you are an Oxford House resident, but you are not on MAT. However, there's at least one other person living in your Oxford House who takes MATs. And then the third group, hey, I'm an Oxford House resident utilizing MATs. And we have pretty good size groupings for our analyses in this sample. Okay, here are the results. Table very similar to what I showed you before. Keep in mind that the numbers are a little bit smaller because we're looking at those whose drug of choice involve opioids or heroin. And we have three groups. I just mentioned them. The non-MAT house, nobody's on MATs living in that house. The MAT house, at least one person, fellow resident, is utilizing medications. And then we have MAT residents, the individual themselves utilizing medications. Same four questions as before, right? A positive endorsement indicates negative attitudes. Well, I'd like to draw your attention to the MAT house and MAT residence columns. Again, just like in the first Washington College study, the numbers are statistically similar. The proportion of people who endorsed positively these items is basically similar, whether you live in a house with somebody utilizing MAT or you are the person utilizing MAT yourself. You have significantly lower negative attitudes. 20%, 7%. I know numerically it's different. It looks like they should be significantly different, but they're not. The takeaway is folks in these two groupings report similar attitudes, proportionately lower than folks in the non-MAT house, folks who are not on medications and no one in their house is on medications. These rates are significantly higher. Same kind of a pattern that we saw like the Washington College study. And like the Washington College study, about a third, 29% of the sample reported a history of using MAT. Well, we queried further and we found that among the non-MAT residents, people not currently taking MATs in this investigation, about half of them reported a history of being high on their medicines, and about another half reported using MATs without prescription by way of diversion. So folks presently in this investigation not utilizing MATs have a history of using medications for the purpose of getting high, or at least they got high while they used them, and they were doing it without medical supervision, without a prescription. When asked the same questions of those currently using MATs, the numbers were much smaller. A significantly smaller proportion of residents said, yes, I feel a sense of high these medications, and yes, I'm taking these by way of diversion, which kind of isn't really that cool, but it's a lot less. And it's important to compare these two groups, because if I was in the first group, the first non-MAT residence group, and I have a history of using MATs, my experience is going to inform me as to what I think these people are really doing. But if I'm living in a house with them, maybe I realize, oh, they're going about this in a very different way than what I was doing back in the day. And like the Washington College study, there was no difference between the groups on important recovery outcomes. Continuous abstinence, continuous days living in an Oxford house. And unlike the Washington College study, we gave out the AAAS, the Alcoholics Anonymous Affiliation Scale, and we looked at 12-step involvement. There's a misnomer that some people on MATs can't get involved in 12-step service. You can. There's a number of service requirements that don't require minimum clean time requirements. So I'm imagining that folks in this study who are on MATs were able to get these service positions in their 12-step groups, because there's no difference whether you're on medications or not with respect to connecting to the 12-step community. And I think that's huge, because when I started this project, I'm reading literature, and clearly 12-step community was not very receptive to people coming in on medications. I know that this is going to be a topic for another webinar offered by I-STARR. Anyway, I'm just going to bite my tongue. I have a lot to say about that. Let me stay focused on what I'm here for. Because I think there is something about 12-step recovery and medications. And I think the zeitgeist now, since 2020, is, hey, these are not mutually exclusive. Let's bring the both of the best together to really understand what's going on. So I like it that we stop demonizing big pharma and stop demonizing the 12-step people. All right, so the takeaway, well, recovery home residents, at least those living in Oxford House, have much more favorable attitudes than only a few years before. That with a more representative study, we're finding out that Oxford House is probably a great place for people utilizing medications. They're suitable for folks on MATs, but the reality is some Oxford houses might not be so receptive. They have a set of traditions that govern their operations, and their fourth tradition is each house has the right to be autonomous, except affecting other groups or other homes or Oxford House as a whole, something like that. So it's quite possible you could go to a house and there's a bunch of guys, these old alcoholic men who go to AA, and they might say, hey, we like you, John, but we're not going to vote you in. You're a druggie. We're all alkies here. We only take in people who we can relate to. You might want to go down the street. There's a bunch of druggies over there, and they're a real good bunch of guys, and we think you'll do well there. And that happens. Houses have their personalities. It's not just based on drugs of choice. So we're suggesting that people go to Oxford houses on medications and check out a number of houses in their area. Some would be more receptive than others with respect to the use of medications. But I see this as a trend that's continuing to improve. There's been a lot of outreach effort from the Oxford House organization making presentations to homes about the use of medications and the use of Narcan. Okie dokie. So the next study examines social support, something that we've done for a while. Been in a number of studies with Dr. Jason, who's been looking at Oxford House for decades, I think 4 decades. And, he comprehensively looked at social support, and now he's looking at social dynamics of social networks. We know in the addiction research world that social support is a good thing. There's about 100,000 empirically based studies showing the psychological and medical benefits of having social support. We know social support reduces stress. We know that stress increases negative outcomes. And in the addiction research world, we know that it can be a threat to things like self-efficacy and quality of life. We know some of this about the relationship between these concepts with folks recovering from substance use disorders, but very little is known among those whose recovery is based in part on medication-assisted treatment. We know that they're at risk for tapping into social support because the 12-step community has not been so warm and inviting when they come to meetings. Is it possible that the Oxford House model might be able to help? So I'd like to go over what seems to be a complex data analysis. It's actually very straightforward. I'm going to show you 2 pathways, 2 mediational pathways. And to explain my point, I want you to take a look at stress on the left side of the screen. Then there's an arrow going across to the right, looking at model 1, model 2, quality of life, absence, self-efficacy. Simply, this pathway says if you have a high level of stress, you're going to see decreases in quality of life, decreases in absence, self-efficacy. In other words, one's belief or confidence in their ability to effectively engage in a number of behaviors toward the goal of recovery. So when people are stressed out in recovery, it affects their quality of life. It affects their self-efficacy for their abstinence. Now, social support on the top, basically saying if we add that into this equation, we're going to lessen or buffer the ill effects of stress. That stress won't be so harshly attacking our absence, self-efficacy, or our quality of life. Now, to throw a little analogy, it's sort of like when you have a bad stomach acid, that leads to stomach pain and farting. Well, if we take Alka-Seltzer, could that mitigate it? Could it lessen or buffer the effects of the stomach acid? That's sort of the analogy here. So I want you to think, okay, with social support, if individuals connect to social support, that could buffer the effects of stress. And here, to really understand this among folks on medication-assisted treatment, we have to do what is called a moderated mediational analysis. It's very simple. We're looking at these pathways for both sets of residents, those on MATs and those not on MATs. But we have to construct the analytic model this way using Preacher and Hayes's process model. I'll try and make it as simple as possible. Here are the results. Pay attention to these numbers, these coefficients in black font, but pay attention to those of the pink and green. You'll see that there's an asterisk associated to these. These are beta coefficients. They are unstandardized. meaning if they were standardized, you could kind of compare one to another. You could see incremental differences in the dependent outcome based on their values. But when they're unstandardized, you can't. But to really understand this sort of an analytic model, you want to know, is the moderator significant? And there are two categories of moderator, MAT and non-MAT, right? Residents on MAT, those not on MAT. Those who are not on MAT are in the pink line. So this is significant because there's an asterisk placed there. So for those people not on medications, social support will interfere and buffer the effects stress has on quality of life. But the same is among those utilizing medications, as evidenced by the green coefficient, which is significant because you see the asterisk there. So regardless of the category, social support works in terms of buffering the ill effects of stress, not only on the quality of life, but also when the outcome is absent self-efficacy. There is a test, however, to take a look at these two coefficients to see whether they are significantly different. It's a test of moderation. And in both cases, the result was not significant, meaning social support equally benefits folks in Oxford House, whether they're on medication or not. And this is important because we're looking at outcomes that are not specific to abstinence, but things that could apply to folks who have different pathways, however you want to conceptualize recovery. In other words, abstinence, self-efficacy, and quality of life. The third college study, or the third and the fourth one, looked at a sense of homophily, meaning I have a similar experience with respect to my medication use. I'm basically going to reanalyze what I just showed you by trying to understand that sense of proximity. In other words, does it make a difference if I live in a house with someone else who's on medication versus I'm the lone wolf in my house. I'm the only one on MATs. So to examine this, it's the same thing I just showed you, only we're going to be looking at folks who utilize medication-assisted treatment. If they're not utilizing medication-assisted treatment, they're not going to be part of this analysis. So that homophily with respect to their MAT use, that's the moderator. In other words, whether I'm living with others on MATs, at least one, or no, zero, zilch, I'm the only one in my house utilizing MATs. Does that have an impact on the analytic design? So here we go again, same kind of mediation model. The only difference has to do with the moderator. And we're not saying MAT, non-MAT, we're saying MAT, homophily or no homophily, living with at least one other MAT resident or not living with another MAT resident. And the results are kind of striking. Unlike what I showed you before, the coefficients of the moderator are different. That when it comes to living with a MAT resident, yes, social support reduces the ill effects of stress. But if you're a resident on MAT, not living with at least one other person in your home, that social support is not going to buffer the effects of stress, whether the outcome is quality of life or absent self-efficacy. So we know that social support is effective for everybody in an Oxford house, but more effective when there's at least one other person on MATs living in that recovery residence. Okay, and the last analytic study that I'm going to talk about is going to be a different pathway involving psychiatric severity and stress. We know that psychiatric problem severity, regardless of one's diagnosis or one's symptoms, is not a good thing. This is something that is measured by the Addiction Severity Index. It's perhaps the most reliable score index of the whole ASI. This is a widely regarded research tool in the addiction research world. And psychiatric severity index is going to lead to decreases in important health outcomes and recovery outcomes that we know. We know stress is not a good thing. We know that stress could worsen one's psychiatric problem severity. So we know this to be the case among folks recovering from substance use disorders, but very little to nothing was known at the time about folks who are recovering through the use of medications. It's been reported that their stress levels are off the chart. They're a lot more stressed than other people in recovery. Don't know about that. That they tend to have more psychiatric issues than other people in recovery. Don't know about that either. But I don't know whether there is something that could help folks on medications with high levels of psychiatric problem severity and high levels of stress. So there's a need to know, can there be some kind of double whammy effect that's going to put people on medication at greater risk than they already are? And could living in an Oxford house do that? Could living in an Oxford house take some of the edge off the effects of the stress that it might have on their psychiatric problem severity? So in order to do that, check out these apples. Same kind of approach to analysis where psychiatric severity, the extent that one is troubled or bothered by their psychic problems, when there's a high level of that tends to predict decreases of absent self-efficacy and quality of life. When stress is entered in the picture, it makes it worse. So the analogy here is like you have that stomach acid, and yeah, you get the stomach pain and you're farting, but sort of like introducing you to having some greasy French fries. That's only going to make things worse, right? So stress is only going to make the effects of psychiatric severity worse. Homophily is the moderator. In other words, do the ill effects of stress affect folks on medications when they're living in a house with at least one other resident, whether they're the lone roof? We don't know. Let's check out the homophily effect here. And as a control group, how about non-MAT residents? Maybe they're equally affected by stress. Maybe the stress thing is not only an exclusive quality of people whose recovery is based on medications. Here are the results. It's very simple. Keep away from the black font coefficients. It's just the pathways of the major variables. Take a look at the blue coefficient to start with, minus 5.29. There's no asterisk. It is not significant. This is in reference to people in the non-MAT group, so they're not taking medications. Basically, for these folks, when they're highly stressed and they have psychiatric problem severity, well, the stress is not going to worsen things. We're not giving them the greasy French fries. We're not giving them Alka-Seltzer, but we're not giving them greasy French fries. It's not going to have a significant impact. But what about the pink and the green coefficients, those in the MAT groups? The red coefficient, MAT plus group. It means that there's a change, and it's lesser than those in the MAT minus group. Meaning the effects of stress is greater among MAT residents who are the lone wolves, who don't have at least one other person in their house, where the effects of stress are there, but to a lesser extent among residents who have at least one other person living in their house. So the homophily effect seems to be a protective factor against stress for folks on MATs when the outcome involves self-efficacy for abstinence and quality of life. All righty. This is kind of cool, I think, because it's showing some kind of support for the notion that folks have hinted that folks on medications might have additional stressors. And if they have psych problems in addition to that, they need help against this double threat. And that could be lessened when they're living not only in a recovery home or sober living home, but one where there's at least one other person like them on the medications. Okay, and lastly, something I'm going to talk about for about 30 seconds is study number 5 that is forthcoming. I had the honor to serve as a thesis chair for a former DePaul student, Noor Arjman. She was a volunteer for Lenny Jason's Center for Community Research. She went to Columbia to get her master's in clinical psychology. She asked me if I could help her do a research project. I said, sure, I'm collecting data right now. So she wrote up the cross-sectional data and did some analyses. And I think this is publish worthy. I think that there's a need to be very descriptive with respect to characteristics of folks living in recovery homes such as Oxford houses utilizing medications. She found that there's basically no difference whether the medication type had to do with methadone, Vivitrol, or Suboxone. There's some sophisticated inferential tests that were used to demonstrate that. But I think the real jam in the paper is to show data about various characteristics like the type of medications or how much are they using, how long have they been on it, are they involved in case management? Because I think this would open the door for other investigators like you to maybe ask when you're collecting data, trying to understand recovery among those taking medications and or living in recovery homes. So with that said, I think it's important to look at various types of social support. I'm the kind of person I like looking at types of social support, found some interesting findings about women ex-offenders where tangible forms of social support was equally important as their social support for their abstinence. Who would have thunk? Um, so different types of social support. I know that Lenny Jason's looking at social dynamics, some very interesting findings there in the social networks. But let's take a look at different aspects of social support. Um, are they specific to the residents of the house, the 12-step community, maybe one's outpatient, maybe one's MAT network, maybe it's something that's MAT specific that could help us better understand the positive influences of social support. Longitudinal research is needed. Comparative designs cross-sectionally are nice. I had set out with some help from the Oxford House organization looking at folks on MATs over a period of time, every, I think, 6 months or 3 months. And I had a dynamite crew of trackers. But as it turned out, like the 209 people who said yes and gave us baseline data said no for the subsequent assessment intervals, like giving them a chance to win $100 gift card was not cutting it. And this is all unfunded. So really, folks, when you apply for your grants, make a big budget for incentivizing your clients. I think this might be a little bit harder to get these days. People aren't so generous. It's a Gen Z thing. I don't know. But with the longitudinal designs, I was kind of hoping to look at changes in maybe the use of medications, whether they're on, for example, a taper protocol. Are there changes without relapse? If so, what attributions can we make? Is it something about the house characteristics? Is it something about their social networks? Why is it they seem to be reducing? Or are they reducing against medical advice? Who knows? Are there differences between folks on a taper protocol versus a maintenance plan? Do histories of being on MATs kind of set a trajectory of success? We can only answer or start poking in these questions by doing longitudinal designs. And I think it's really important to take a look at the pharmacological and behavioral aspects of the comprehensive approach to treatment, like 12-step involvement, things outside of the individual, things within the home, maybe intensive outpatient, things like that. And lastly, we definitely need to consider, home structure effects and house size. Please, if you're doing recovery residence research, ask questions about how many people live in the house. This comes up a lot in legal matters. There's been a small handful of studies showing evidence that when you increase the size, you're going to increase the therapeutic benefit. So we need to do this for folks utilizing medication-assisted treatment. And that is it for me. So I am going to pass this back to Amy.
Wow, what an amazing presentation. And again, I feel so lucky that I-STARR has access to you on our advisory board. I know that I have benefited from your 3 decades of research. I'm one of the people who cites this research in my own work. And what a wonderful opportunity to hear all about your work in this field and on this topic. I do have some questions for you, but I'm guessing that audience members do as well. And we have about 10 minutes, folks, for Q&A and discussion. We have access to Dr. Major, so feel free to drop notes into the chat, your questions into the chat. Also, feel free to raise your hand within Zoom and unmute yourself. We can call upon you. And just kind of scanning through to see if I see folks with hands raised. Maybe people are still formulating their questions. One question that I had for you, Dr. Major, is given that this is several studies, you've been in the field for a while. Have you seen changes over time, and how would you characterize that?
Can you specify what you mean by changes over time?
Changes, with respect to the attitudes, towards MAT, and MOUD. I know that your first study, you did, mention that that was the first and not the last, and that things are looking more hopeful. Can you expand upon that a little bit?
Yeah, certainly. Um, I can tell you that I go to Oxford House conferences just about every year. And around 2009, 2010, this came up. I think I led a panel like down on DRTs, and now people are coming to the houses. So there was some kind of resistance, and then I'd have people in the audience say, "I don't know about these people," and then they weren't saying that during the presentations. They pulled me to the side. Well, I don't know about these people. And then you bump into people saying, "Hey, wow, we got people, on these medications in our house. This is really working." So it's changing, and there's still some people like they're not buying it, or maybe their experiences that there's going to be some kind of misuse, but you're going to get that in any kind of recovery home. I mean, I'm a little bit of a conspiracy theorist. I know big pharma. I've read Selling Sickness from Castles and Moynihan. I know that there's a way to over market these medications, and it really sucks because it's going to leave a bad taste in the mouth of people when it comes to realizing I was marketed a drug, it doesn't really work for me, therefore it doesn't work for anybody. And that's going to harm people who, I think, like people who need a recovery home. There's some people they're only going to benefit by connecting to medications for their recovery. So I think that there's a better attitude among the 12-step people. There's less judgment about it. So I think that things are getting a little bit better, but we need to identify as researchers, okay, the combination of things. Like I think Mark Galanter said this in a publication in 2020, and I think a lot of people in here, myself included, embrace, we have to look at both sides. It's not just all or nothing. And, community immersion is a great thing. I can tell you, I messed with people in the 12-step groups who were clean for a while, got on MATs and died and overdosed. And I'm not convinced that MATs is going to reduce the opioid crisis fatalities. It's sort of like if we buy more guns, we're going to have more shootings. We have to do something different. And I know people who are dying, and we need more research to govern this practice because people are dying with these medications and they're dying without it. We are the ones who have to figure out what's the right combination as a best practice to ensure one's health and well-being. So I hope I answered your question.
No, that's excellent. I see Dr. Jason with his hand up.
Oh, God help me.
John, very nicely done. Thank you for giving us a nice overview. Just wanted to check, you see that the use of the MOUDs, the attitudes might be similar within more traditional recovery homes versus Oxford houses or self-help. I know that there's some people, for example, who feel that the brain needs maybe 5, maybe more years to really begin to change enough so that a person potentially can be off these types of medications. Do you think that that is something that would make folks want the professionals to kind of keep people on versus some people in some of the kind of abstinence-based approaches wanting to get off quicker?
Well, when it comes to Oxford House recovery homes, I think Oxford House is head and antlers above the rest. They're really trying to get the word out in terms of educating residents about the use of medications, the use of things like Narcan in the case of an overdose. So I think education is key. I think other recovery homes, well, it depends. Some might be all about it. Some of them absolutely not, go somewhere else. So I don't think, I think Oxford House is going to be the leader. It's my sense. In terms of being on for 5 years, where's the data? I used to work with psychiatrists whose word was golden because they had the MD. They never had to be accountable, except for my pre-doctoral internship. where we had to make the case in front of our supervisor, who was a clinical psychologist. I won 10 out of 10 times because I'm very evidence-based, where he would always be like, "What's just my opinion?" So we have these doctors who are prescribing. I hope they're informed, but what is the science behind the decision making about how long a person should be on it? What is the correct dose? We have a lot of research to do. So I can't really answer that. I think that, there's going to be some kind of power saying this is what should be the case. Like a publication that NAR, I think, took off their website, National Alliance of Recovery Residences. It had to do with medication use among people in recovery homes. The opening sentence of this publication was, although there is no science governing how long and how much a person should be on these medications, comma, we know that medications are the gold standard or the blue ribbon or something like that. So I can't answer that question, Lenny. I can say that we need to generate data to maybe inform medical practice as to helping them make that decision. I hope I came close to answering your question.
That was good. So, John, I'm also wondering if you could talk more about homophily and to kind of break down that term a little bit for folks who may be hearing it for the first time, because it did seem that that was an important construct in terms of making sure that people had better attitudes and that translated into better outcomes for residents. So, can you just revisit that a little bit?
Yeah, it's finding somebody who's has similar life experiences as you. And I think most people early in recovery, they see the vast differences, and it's very difficult for them to find the similarities. In time, if they hang in there long enough, they start seeing how similar they are to their recovery peers. We all are members of the same race, the human race, but we have these diverse human experiences based on our sexual orientation, based on our race, our ethnicity, things like that. Our drugs, there is a sense, I want to say hierarchy, maybe it was many years ago when I first started going to meetings, the intravenous heroin users and the PCP smokers and the crack cocaine smokers were the hardcore addicts. People who use alcohol, that's nothing. And wow. And now Narcotics Anonymous has evolved in the last several decades, where it's like, hey, it's the underlying condition that led to the drug use, dummy. If you don't get with that, you're not going to stay clean and sober. So with homophily, I think that for people on medications, that's a very important issue that makes them separate from others, whether they perceive it or they're picking up on that vibe. It's like, being a veteran, being an orphan, being gay, or I only use prescription drugs. I'm too old. I'm the old man in the house. People feel a sense of distance, but if there's somebody like them with respect to their age, their orientation, their ethnicity, their drug of choice, it makes it a little bit easier. You see it working for them. You're like, well, if it could work for them, it might work for me. So by homophily, it's not like, okay, we're all, people in recovery, but with this in relation to something specific, like, wow, this person's also using medications. Sweet. I want to hang out with this person because this person might give me that hope shot I need to, stay in this house, because I don't really think I can be like these other people because I'm on medications.
So a good synonym would be similarity, and that would be even probably better than familiarity. You can understand something. It's, being able to really, you've experienced something. You're familiar with something. That would be homophily.
Yeah, that'd be a good way of saying it. Similar experiences.
Mhm.
And one thing I think I said at the very end of my presentation, we need to take a look at house size, because something that I've testified a number of times in these cases where they're trying to push the recovery home out of the neighborhood because, oh, there's too many people in there that, and I think the best argument you have is say you want to maximize the number of rooms, the number of residents in this house without causing overcrowding, but you want to maximize it to increase that social microcosm, to make it a little bit more likely that the individual finds common ground on some issue of human diversity with one of the fellow residents. So, familiarity, similarity, somebody like me. That's very important. And let's face it, you're a person on MATs, given the history in the last 10 or 15 years, there is a sense of shaming or a sense of not accepting or just making the attribution this person is full of crap and they're still using. But if there's another person in the house, that other person could keep me in there, and then I could demonstrate to my peers who aren't on medications, hey, yeah, we are a lot like, only I started my journey on this pathway. We all came in on different rafts, but we're in the same boat now. We have to realize that we're all in the same boat. And it takes a while for each individual to go through their own individual process to determine that.
Excellent. So I think that we're going to wrap up the Q&A, but folks, if you have additional questions, drop them into the chat, and we'll pass them on to John. I do want to give people a heads up about some things that are coming up with I-STARR down the road. So next month, we'll have another webinar, and that will be on the topic of MOUD in 12-step groups. And we'll be hearing from one of our I-STARR team members, Dr. Sarah Zemore, as well as Dr. Barry Raymond from Recovery Unplugged. So I'm super excited about that. That's in November. And in December, we'll be hearing from Jody Dewey, who was on this webinar for a little bit and then had to scoot off. But she'll be presenting findings from her I-STARR pilot study, where she focused specifically on recovery housing for folks who are involved in the criminal legal system. So unless otherwise advertised, the I-STARR webinars are always held the third Tuesday of the month at the same time from 11 to 12, and that's for folks on the West Coast, which is from 2 to 3 for folks on the East Coast. You can register for any and all of the webinars, I-STARR webinars that we have scheduled on the I-STARR website, and we can. Excellent, we've dropped it already into the chat. And you can also stay in touch with I-STARR and I-STARR activities on our website. And while you're on the website, you may see information about the I-STARR training series. And for folks who've been to webinars in this I-STARR webinars before, you may have attended an I-STARR training series webinar. But if you haven't, the training series is a suite of 12 webinars with different tracks, one track for recovery housing operators, providers, and another track specifically for researchers. Folks who view all of those webinars, those 12 webinars in the different tracks, can receive a certificate of completion for, again, completing the training series, and can be listed on the I-STARR website as someone who has completed the training series. For folks who complete the training series, the operator provider training series, you can actually earn 12 CEUs, NADAC CEUs, for completing the series. If you want to participate in the training series, because we've already completed it, you can't attend live, but you can participate through our learning management system. And I would encourage folks who are interested in attending or viewing those webinars in the training series to do so through the learning management system, because that way we can track your attendance. We can't track your attendance if you're just kind of clicking on the video from the website. You have to register in the learning management system to have your attendance tracked. But we hope that folks will take advantage of that. And, we have 7 people who've completed the training series thus far, and we hope that we have several other folks complete that training series as well. So we are at the top of the hour. Let's go to the next slide. I just want to thank again Dr. Major for his presentation, and again for his work in this field and on this topic. It's been pivotal and on the front line, and I feel really lucky that we were able to hear from him today. And thank you to everyone who was in attendance today. We really appreciate your attention and your time, and we hope that we see you again next month to hear about MOUD and 12-step groups. So take care, everybody. Bye-bye.